Hey, it's Dr. William. Grab your markers.
Have you ever wondered why
Lipo through the key area, round, fill in the hip, blend that into the leg.
I've got my pen and paper out today. I want to talk about...
Okay, relax.
Welcome to my YouTube channel.
Hey, it's Dr. William. Grab your markers.
Have you ever wondered why
Lipo through the key area, round, fill in the hip, blend that into the leg.
I've got my pen and paper out today. I want to talk about...
Okay, relax.
Welcome to my YouTube channel.
Hi, welcome back. If you're just joining us tonight for the first time, then welcome. And if you joined us last night, then welcome back. Last night was part 1 on how to prepare for having a BBL. And tonight is the second part of that series. This whole class is really aimed to educate you the best that I know how as to prepare yourself for a BBL. Last night was pretty heavy. Tonight won't be quite as heavy. And we're all going to have a little bit more time tonight for questions as well. This was the outline yesterday, kind of talking about all the things beforehand in terms of, you know, if a BBL is right for you, what's a BBL, how to choose your surgeon. If you missed last night's live broadcast, then the video is up on my YouTube channel and it will be available for another day. And then we will be taking that down. There's some links in the comments section for 2 PDFs that I gave out yesterday that are both good. So if you haven't seen that video, you can watch it for tomorrow and download the PDFs. And tonight I'm giving away 2 more PDFs Both have great information. One of them is really cool, and I'm gonna save that to the end. Let's get started, and we're gonna, remember, we did all the preparation yesterday. So now we're at the point, we're kind of taking this through almost like real time. And so now we're at the point where you're gonna have a consultation. So you've decided you're gonna have a BBL, you've picked your surgeon, all the other things. Or maybe this is your first consultation and you're planning on having more, but this is sort of some of the things you can do to prepare yourself for the consultation. And I'll give you a different perspective as well, because I'm gonna tell you what we are thinking, what surgeons are thinking, at least, you know, quite a few people that I've spoken with, and some of my thoughts, and so give you a surgeon's perspective as well as a consultation, because we also have an agenda during the consultation. I know you have an agenda where you want to decide, is this the correct surgeon for me? But we also want to decide, is this the correct patient for me? So we're going to get into a little bit of that as well. And then we're going to be talking about what you do a month before surgery, and then what you do the night of and kind of the day of surgery. And then I'm planning on having a second course on how to prepare, or how to recover from a BBL rather. That's going to be in November. That's also going to be a 2-night course starting same time at 7 o'clock. And from that point, we're going to go from, okay, you've had your surgery, and then all the way out to the 1-year mark. So these two classes are meant for the preamble, and those two classes in November are going to be take you the rest of the way. So after you've seen these 4 classes, attended these 4 classes, and have seen these 4 videos, got the accompanying PDFs, then you're going to have a complete class already on everything you do from soup to nuts. So, okay, let's get started. So this is some advice I would say that I would give you for having a consultation after having done many consultation myself. And I would sort of discuss or think about discussing the plan with your surgeon and what your eye is. I'm always kind of talking about your eye, and what I mean by that is, what is it that you like? What is it that you want? What's sort of the look you're after? And everybody kind of has that innate eye in them. It's why we marry our spouses, or we think some people are good looking and other people are not as attractive to us. And it's variable from person to person. Every pot has a lid. And so I think it's important for you to think about what you're looking for and to have that discussion with your surgeon during the consultation. I would not suggest showing wish pics. I know some surgeons do use them, others don't. I've certainly talked to many of my colleagues. A lot of them don't like them for the same reasons that I don't, is that they give patients a false image, which can lead to disappointment after, and that just creates a whole bunch of problems. As you know, we're all different. I would make sure when you're leaving a consultation that you have a clear understanding of where the scars will be. We can't always tell you exactly to the last sort of centimeter, because we make those decisions on the table when you're asleep. Basically just as a matter so that we can perform the liposuction in the very best way. And it's just sometimes having an incision a centimeter over or a little bit down or whatever can just change the angle enough and keep your wrist and your elbow and your shoulder in a comfortable position for you to do the lipo and to get the areas of fat that you need to get. And so I know sometimes people ask me in a specific location to make a scar, make an incision. If I can, I do, but most of the time it's just too difficult because it changes from the time the patient is sitting talking to you or when we're standing marking them to when patients are laying down. But I would make sure that you have a general idea of where the scars are going to be, the areas that you're going to have for liposuction. It is a problem. It really hasn't happened to me very often, but it has happened to me where there's been some disconnect between myself and the patient in terms of what areas are going to have liposuction performed on them. So some people assume that arms are included with Lipos 360, which is not the case. And so sometimes I have had patients be unhappy afterwards saying, hey, you didn't lipo my arms, but that was never part of the plan. But I think that they assumed that was included. So make sure that you know the areas, and then discuss also the location of the fat grafting. And that's going to come back to where your eye is. And I usually mark everything where I think they're going to go according to the OG, but patients will ask me, and I had someone ask me today, where is the point of maximal projection on my hip going to be? Again, it can change in the operating room a little bit, but generally I mark that out beforehand, and so I can tell you, this is my plan to put the point of maximal projection there for the hip. And you want to make sure that you're on the same page and you're not coming out with something that you didn't expect. I think in my situation, I feel fortunate because of my educational videos and my kind of standardization of doing things and my strict adherence to following the OG line. It's a little bit more predictable for patients that see me for consultation because they sort of already know what they're getting. It's kind of like going through McDonald's getting number one. Not that I've done that for a while. What day is it? So then you're also going to want to express your size concerns and what you're looking for. Everybody has different desires, and some people want to be as large as they can be. Some people want to look more artificial. Some people want to look more natural. So it's important to express those feelings to your surgeon and discuss them. That's a good time when if somebody says, I want to be really big but then you're examining them and they have very poor soil or low soil or no distensibility. And that's an important time to have that discussion. It's our obligation as a surgeon to inform you as a patient, I understand this is what you would like, but this unfortunately is what your tissue is going to allow us to do. And you have to have that. The number one reason, and I've seen it with my patients, I've seen it when patients come to see me from having surgery with other surgeons. I know all surgeons have seen these. Is patients are unhappy usually. They're usually unhappy because, not because their surgery was poorly done. They're usually dissatisfied because it wasn't what they expected. And that's the most common thing you'll hear. If someone comes in and they had a breast lift and they're lower, they will say, well, I expected them to be higher. I expected them to be fuller. I expected my hips to be bigger. And so there's a whole group of expectations that the patient will have. It's normal, it's logical, but that doesn't always fit with the patient's anatomy. And you're not in a position to really know that very well because you're not a plastic surgeon, you haven't done all the surgeries. But if you look at it from our point of view, you could say somebody expected this and you'd be like, oh my goodness, how could that be possible? Here's the before picture. You can clearly tell that would not be a possible result. So it's really good to explain to your surgeon what your expectations are and to find out if those are real and if they're possible. And I like to be totally transparent. If I don't think they're possible, I just say I can't do that. Sometimes I don't know, and a lot of times I don't know. And I really just say, listen, I don't know if your tissue is going to pop to get the type of hip that we want. I don't know if we're going to be able to get the type of projection. Your waist is not particularly small naturally. I don't think I'm going to really be able to bring it in. I say that. because I don't want anyone to be under the misunderstanding that I can. But what I do say is, I said, I can promise you I will try as hard as I can to get the projection or whatever the issue is. I'll try as hard as I can to get that. It's just I'm limited by the anatomy of the patient. So having that realistic discussion about those things, I really think it's probably the most important point about having a consultation, is really to get down to that nitty-gritty. That's why I think, I feel for my patients that they're under a better understanding of what I'm going to do and what I'm limited by doing just from watching the videos. And it allows us to have a little bit deeper conversation, because we can kind of focus not on how many massages do I need or how long do I wear foams or those types of questions, but really focus on the important surgical questions that leads to better satisfaction and better results. Now, from a surgeon's point of view, and I'm just going to say this image here is a little foreshadowing of the second PDF that I'm going to show you at the end of the night. But from a surgeon's perspective, we have a little bit different view. So we want to make sure that you're fit and that you're safe for surgery, that you're healthy. That's our primary concern. We want to also make sure that you're capable of recovery. As I mentioned last night, this is a very difficult recovery. It's a big operation, and you need to be capable. Sometimes I've told patients, I don't think you're ready for this surgery, or I don't think you're prepared to have this operation. And patients will be taken aback, because like, well, why? I've paid for my BBL, I'm here, I'm ready, you got someone to drive me. But there is so much that goes in, as you witnessed last night with that grueling lecture, that there's so much that goes in to preparation for having a BBL that you mentally need to be prepared as well. And that's one of the things that I look at when I talk to people preoperatively is, is this person in the right space to have a BBL? And sometimes they're not, and I've had patients who I've said, listen, I think we just need to kind of regroup here maybe in a couple of months. And I can tell you, patients that have gone through that, they may have been experiencing something in their life personally, either relationship or job or something else, that they later said to me a couple months later when they came back for their BBL, they said, you know what, I'm really glad that, I was really pissed at you before, but I'm glad in retrospect that you told me I wasn't ready, because there were these things going on. And now these have resolved and I feel good and I'm in a right space to have recovery. So we're looking for those signs as well, to make sure that everything is lined up and that you're prepared to go through this recovery. We're also looking to see what type of support system you have. Is this something where your cousin who you barely know is going to be looking after you? That's not an ideal situation. We're going to be distributing a PDF today is going to have some instructions for your caregiver. I just emphasized it so much yesterday, but I want to say it again. Your caregiver is going to be the most important person for your recovery, because they're going to be looking after you. And so having an adequately informed, prepared caregiver who's really into it, who's enlisted and there with you, is very important. So assessing whether you have that support system is also important, and part of what I'm sort of running through my head when I'm meeting with somebody preoperatively. Also want to make sure that they're realistic with their expectations and they're listening to me when I say, we are going to have a difficult thing here or this. I tend not to be that type of surgeon who's like, oh, baby, you're going to look so hot and stuff like that. That's just not my personality. So it's kind of like if I don't say something's bad, then it probably means it's good. But I usually try to point out things that I feel that I might have difficulty with. And so I want to make sure that the patient is listening to me and hearing what I'm saying, and then they do have that realistic viewpoint. And I want to make sure that they're emotionally stable. Kind of touched on that already, but I want to make sure that they're in the right place to have surgery. So these are all the things that are running through my mind, and probably most plastic surgeons' mind during a consultation to make sure that everything's good. So that's our perspective, and I think it's kind of helpful to know that. So let me start off and talk about a bad consultation. And there are bad consultations, and they just don't go well. And I'll tell you what I think is the reason why they happen, not for every case, but for some reason. I think it's because my experience is when I've had bad consultations is when it's really heavily patient driven. And I know that sounds like such an egotistical thing to say, like, I'm the doctor, I need to control this consultation. It's really not meant that way. But if the patient really has a strong agenda before they come in and they start telling you the agenda, I really feel that they miss out on a true consultation, because you're there to get your surgeon's opinion as to what they can do for you. And if you're really spending most of the time talking and giving them information, you're really missing out on the opportunity to gain some information. So I find that if it's patient-driven, the patient's doing most of the talking, there's a lot of misinformation being said, a lot of misconceptions being laid, and a lot of these false statements. It really becomes a very unsatisfying consultation for the patient and the physician, because we don't really accomplish anything. And here's an example. I'm just going to kind of read you through this, of a patient-driven consultation where they're going to kind of come in and really take over and tell you things. So it will say things like, so I know you can only take 4 liters of fat. Will that even be enough to get the result I'm looking for? Because I want a lot of projection and a real fake look. Well, already it starts off with a erroneous statement, because she's making an assumption that 4 liters of fat is not very much fat. 4 liters of fat is a lot of fat. It's a lot of fat. And especially now with some of the techniques that we use to concentrate the fat, 4 liters is huge. So then the surgeon will say, well, 4 liters is a lot of fat. Most people, there's no way you can put 2 liters in each side. And then the patient will say, well, because a friend of mine didn't have a lot of projection, so put in extra for me because I know that 70% of it dies. Well, 70% of the fat doesn't die. You can't put extra fat in because it's like filling a glass of water. You can only fill it to the top. You can't say, oh, some of that water is going to evaporate, so put more in it. You can't. All you can do is fill that cup up to that glass, up to the top. So there's a couple of misconceptions going on. And so then you'll see then I would reply, well, 70% is a little high. 70% of the fat doesn't die. You can't put more fat in, filling all the way up, And so what that leads to is there's a lot of confrontation, because I'm kind of correcting the patient, which really gets annoying for the patient. And I hate to do it, but I don't like these falsehoods. So we end up in this little scenario where I'm thinking this patient is really misinformed. She doesn't really know what she's talking about. And then because I'm contradicting everything the patient is saying, the patient's thinking the same thing. Oh, this guy has no idea what he's talking about because my friend told me 70% of the fat dies. And so it's really a adversarial kind of relationship that's made even worse if the patient or the doctor don't listen. And that happens. And I'm certainly guilty myself. I try to focus on being a good listener, but I'm not always successful. And sometimes patients, I will speak and you can tell they didn't really understand, acknowledge, or register anything. And so when you get into that type of patient-driven consultation and combine that with no listening, it's a disaster. It leads nowhere. There's no conclusion to the consultation, and it's not successful. You don't really come up with a plan. So What I think is a good consultation is something that's more like a conversation, and it's a dialogue, and there's good, correct information, and the patient and the surgeon are both listening to each other. So that becomes a very satisfying consultation. And from my perspective as a surgeon, it's very nice because you're meeting new people, you're talking to people, and when you have this nice dialogue, it's fun. I mean, it's enjoyable. So I think having an agenda and sort of going in and using a lot of anecdotes and what my friend said and these types of things is counterproductive to having a good consultation. And it's very important to have a good exchange of information before you have surgery, before you let somebody operate on you. You want to make sure you've had a good exchange of information rather than just sort of espousing your agenda. Okay, so how to prepare so that you can have a good consultation? Well, I think doing a lot of background work before you get there so you don't have to spend the time asking those types of questions. Are you board certified? Where did you train? How many cases have you done? How long have you been doing this? Those types of things, I think they're valuable questions to know the answer to, but I think that they're a waste of time during the consultation because I really think you need to get down to that point of expressing yourself as to what you want, listening to what your surgeon, what they can do, and coming up with a plan so that by the end of it, you're like, okay, he or she understands me, I feel comfortable with this, they're listening to me, and the surgeon's thinking the exact same thing. It's a reasonable person, reasonable expectations. I feel comfortable that they're listening because they're going to have to listen to get all the post-operative directions, instructions, so that they can become good, compliant patients so we can minimize any complication. Complications happen. They happen a lot. That doesn't mean they're major complications. That can be an IV being subcutaneous. But something always happens, whether it's tiny or whether it's bigger. But if your doctor and your patient are not on the same page, a minor little detour in the road can escalate and become big problems where they really don't have to be. If you have a good dialogue and you've really come to a good understanding of what is possible and you follow the instructions, you understand the instructions, your outcome is so much better. So I would prepare by looking at the surgeon's credentials, talked about going to the American Board of Plastic Surgeons. You just simply type in your surgeon's name and it'll come up as to whether they're board certified or not. You want to have a board certified plastic surgeon. I would spend some time to look at the surgeon's social media. You can get an idea of their personality, get an idea of what they're looking for, what they like, what their results are. Look at the before and after so you get a style. And then give it some time to think about how you want to look in more specific terms so that you're better prepared to have a good consultation. Think about what's important to you. Are hips something that's important to you? What bothers you? What is your motivation for having a BBL? Is you're happy the way you look? You just want a little bit more volume and a little smaller waist? You want more hips? What is, give it some time and some consideration because that's going to facilitate a good conversation with your plastic surgeon. Be prepared, know your medical history, know the medications that you're taking so that we can determine whether it's safe for you to have surgery. You're going to discuss these realistic expectations. You're going to want to know, what is the follow-up schedule and those types of questions. Those types of questions, I say, are more nurse-based questions. You're going to want to utilize your plastic surgeon's time on the real details of the operation, not the other question about how many massages and those types of things. And you're going to want to know, and I would ask the surgeon, well, what happens if I'm not happy? And that's a whole nother discussion, but there's only a limited number of outcomes that you can have after having plastic surgery, and that is you're happy, your surgeon's happy, you're not happy, your surgeon's not happy. That usually is something that needs to be fixed, and the patient be like, oh, I don't like this, and the surgeon's like, yeah, that's not the way I wanted it, or there's reasons why we can do things in the operating room. They don't always turn out the way we think they will post-operatively. So happy, happy, unhappy, unhappy. The tricky patient is when the patient's not happy, but the surgeon's happy. And surgeon is like, I did everything I could. I looked at it before, looked at her tissue, everything else. I don't think there's anything else that could have been done or that we can do. That's a difficult situation to be in, because that's more of a confrontational relationship. Although I always tell patients, listen, don't make me your enemy. I'm your friend. I'm on the same team as you are. We have different roles on the same team, but we're playing together. We both want to get you to look the best you can. So if you are unhappy, you don't necessarily need to express it in a real adversarial, confrontational way. You can be upset about it. That's totally fine and understandable. There is also a situation I think some patients don't realize is when the patient's happy, but the surgeon's unhappy. And that's been in my situation where I'm like, oh, I really think that could look better. Would you like me to fix that? Or would you like me to do that? I could do a little something or whatever. And sometimes patients are like, no, I feel good. I don't want to have any more surgery. Everything's fine. I'm not worried about that. But those are sort of the four possible scenarios you can be in after having plastic surgery. And I would ask your surgeon, well, what happens if I'm not happy? And it really need to have that explanation that I kind of just gave you in terms of, well, if you're not happy and I'm not happy, we'll do something. But if there's really nothing to be done, you need to kind of talk about that openly up front. I love questions, and I know that may sound a little bit weird because I certainly was at a different time in my career when patients would pull out a list from their purse, and I'd be like, oh, God, are you kidding me? We're going to go through all these questions. You see, like, a whole list. But as time goes on, you really realize they are very valuable to be able to go through and address them. I would, and this is at least my preference, make sure you write them down, so you can write them on your phone in your notes. That's very common for people to do, or write them on a piece of paper. I personally like to read the questions, so usually when I see somebody bring out their phone, I usually snatch it out of their hand and say, hey, do you mind if I read these? And then I can read them much more rapidly because I've heard every single question now with the amount of gray hair I have. And I know what they're sort of asking, so I can very expeditiously go through and answer the questions. And if there's some of them that I think are nursing questions, I'll say, I'm going to have Livia, Karina, or one of my assistants will help you with that when we're finished. But let's focus on question number 8, because that's a real surgical question that I can answer. So I really think that there's kind of 2 types of questions. There are nursing questions and there are surgeon questions. And for the interest of time and to get the most out of your surgical consultation, leave your surgical questions for the surgeon and ask the nurse the other nursing type questions that they will have in terms of your dressings and recovery and those types of things, because you want to be efficient with your consultation and get all the information out of the surgeon that you can that's related to your surgery. Okay, what not to ask, and these are things. Wow, that really disappeared quickly. Okay, what not to ask. So I don't like when people ask me, well, what would you suggest if I was your wife? Because it sort of implies that I would treat my wife better than I would treat a patient. So I personally kind of find that a little insulting. We are professionals. We consider that, we treat everybody the very best that we can. And So I don't like that type of question. And the other thing I don't like is, well, what would you suggest? Because, that maybe was good back in the 1970s, 80s, but I trained to start a medical school in 93. And, we were really taught this is patient-focused medicine. So I prefer if somebody if I say, well, how can I help you? What would you like? And rather than for me to give my opinion what they do, because you think about it, it can be a little uncomfortable. I've certainly had patients back in the day when I did facelifts and noses and things like that, and you'd see someone with a large mole, you would assume that they would want that mole removed. You say, oh, well, we're doing your rhinoplasty, would you like me to remove the mole? And they get offended because no, this is my mole, I didn't ask you to remove it, why are you insulting me? So we get uncomfortable to point out things on patients. Maybe we'll do it in the grocery line when we're waiting there, and we'll say, oh, I would do that, do this, do that, do this. But in a consultation, I think it's best if the patient says, hey, this is what I want, this is what bothers me, and then help work through that with them. Price negotiation, can I get a discount, time demands, I need to be at a wedding this Friday, so can you do that? Questions about other surgeons. We try not to speak badly about other surgeons. We're all doing the best that we can to give patients the best care, and I certainly don't want to badmouth someone, and I wouldn't want somebody badmouthing me. And so I think asking your opinion, oh, what do you think of this surgeon? It puts us in an awkward position. I wouldn't ask your surgeon to guarantee, well, do you guarantee that I'm going to be happy? It's impossible to guarantee that you're going to be happy. It's the only thing that I can guarantee is that I will do the best job that I can. But it's impossible to guarantee your happiness with anything. I mean, it would be like going to a restaurant and you order a meal. So, well, do you guarantee that I'm going to love this meal? My chef thinks it's the best meal out there, but I have no idea whether you're going to like it or not. I certainly am not going to guarantee that. So I wouldn't ask your surgeon for a guarantee. I'm not a big fan personally if patients say, well, I'm the first and I've got 12 friends back home, and if things go well with me, they're all going to be coming to you. I always think of that as a threat, like you better do a good job of me or you're not getting any more patients. And it doesn't. We don't think that way. I mean, I don't really care if someone has 8 sisters that are coming to me. I'm going to do a good job on this patient, regardless of whatever else is happening. And I know I see comments where oh, I didn't get a good result because I'm not an influencer or something. I don't give a rat's ass about who you are when it comes to the operating room. Everybody is washed with soap, drapes are down. And that's part of the disconnect with being a surgeon is we're not thinking oh, this is an influence. No, we're trying to do the best job for that person. And that's really what a professional is. And so I think any sort of comments oh, better do a good job here because I'm going to refer you other patients. We assume that if you're happy, you're going to refer us patients. We don't need to be sort of threatened in that way. And certainly legal threats. If there's any legal threats, then usually the surgeon will just back out of the case at that point, because who wants to get involved in any type of legal thing? So those are kind of topics I wouldn't bring up. I don't think they're helpful. Remember, I'm trying to get a very good consultation, a good dialogue, a good exchange. And I think these things, well, you may interpret them as my kind of pet peeves, but they work, counter, whatever I'm trying to say, they're working against that, having a good conversation. And so I would avoid kind of using those things. There's other things to, my apologies. There's other things to worry about. Let me just fix that. There's other things to worry about during your consultation that kind of be like red flags. And so if you go here, things that I would worry about if I was having a consultation is if somebody went to not a very good training program, or they didn't really have a good set of credentials. I would be concerned if they didn't use ultrasound, or they weren't certified in using ultrasound, or didn't have any experience in using ultrasound. Ultrasound has completely changed this operation, where we see where every single drop of fat goes, and we know where we place it so that it's done safely and we don't have a problem with having a fat emboli. I would be concerned if the surgeon treated the staff poorly or had unhappy staff. And I think having happy staff means that you respect your staff, you treat them well, and you also stand up for them. And I've had times over the years where, I remember right off the top of my head, I had a patient who came in, and she had a trouble finding the office, and she had called my receptionist, and she was frustrated with getting the directions, and she told my receptionist to bleep off. And so they put her in a room, and before I went into the consultation, my receptionist came over and said, boy, she was really quite rude to me on the phone. She told me to go whatever. And so I went into the room, and it was a consultation for filler. And I said, listen, I'm terribly sorry, but I'm not going to be able to be your surgeon to take care of you or administer your filler. And she's like, what? Why? And I said, because you were very rude to my staff, and I don't think that's a good way to start a relationship. And I remember her opening up her wallet, her purse, and she had a bunch of $100 bills. And she's like, you're not going to take my money? I drove here to get filler, and you don't want this money? And I'm like, no, I don't. If you want to leave it, would be fine. But no, but the point is that, you have to stand up for your staff. So if you see that your staff are being treated inappropriately, then if the surgeon's not standing up for them, or they're not getting treated well, you get an unhappy staff, that's a red flag to me in a practice. Office cleanliness, obviously. I think it's a red flag when surgeon avoids to discuss risks or complications, or sort of glosses over them like, it's nothing, don't worry about it, it's very safe and nobody has any problems. I think all of us should be very open to discuss complications and risks because they're real. And then I think finally, does your surgeon listen during the consultation is important as well. Other red flags to see if your time is really rushed. I will say that during my personal consultations, I do move quickly. I'm pretty busy during the day, but I don't like to leave the patient the impression that I'm rushing them. And so when I'm with the patient, they get 100% of my attention, 100% of my time. I like to do it efficiently, and I like to have good, meaningful consultations. And you can do that in a shorter period of time if you're kind of preparing patients to what to expect. You certainly should be a little concerned if you feel pressure to decide on a procedure. If they're like, well, you got to do this, or yeah, you have to do that, or no, there's no pressure. This is elective surgery. So this is not the type of situation where we're rushing your child back to the operating room and they're hemorrhaging, and the father wants to go through extra details. You say, like, listen, we don't have time. We're going to go. We're going to the operating room. And so, sure, that's a time to rush and feel pressure. But this is all elective surgery. So there's no gun to your head. There's no time pressure. I think something else that can be a little concerning is lack of before and after photos. It can give, it may be an indication that the surgeon hasn't done enough of those procedures. Same with kind of vague answers, or something that would concern me is kind of unrealistic promises of great results. I sometimes joke to my staff, I'm like, I don't even know how I have any patients, because I tell them all these things that that could go wrong and tell them all the things I can't do. But, I'd rather be that way and be very open and honest. That's how I like to be treated, no matter where I am, what it is. I'm kind of a worst case scenario. What's the worst that can happen here? Oh, okay, that I can deal with. But I don't like having smoke blown up my culo with these unrealistic promises of these great results. And then the other thing is sort of what's the plan for follow-up. There should be a follow-up schedule, what your typical follow-up is. That should be pretty evident. There's important things for you to mention during your consultation. Things like a previous deep vein thrombosis or a blood clot or pulmonary emboli. You're at higher risk of having another one. So it's incredibly important to mention that. I personally don't operate on anyone if they have had a previous deep vein thrombosis, and sometimes I think people are under the impression that they really want the surgery. They're not going to be forthcoming with that. In fact, I had that scenario about 2 or 3 months ago. And the patient did develop a second deep vein thrombosis. And her sister told me, yeah, she had one before. And we ask everybody multiple times whether they've ever had that. So those types of things are very important to mention because they can be fatal. You can die from a blood clot going to your lung. The same thing if you've ever been on blood thinners. Most of the time, if somebody's been on blood thinners, it's a serious medical problem with their heart or some coagulopathy, so we need to know that. Previous gluteal injections. It's really not as uncommon as you may think it is for patients to have foreign material injected in their butt. In South America, we have a lot of patients from South America, and in South America, it's not as common now, but there were very frequently injections performed by doctors in medical clinics, and it was legal. And so some of those patients are now living in the Miami area, so we'll come across them. And then there are also patients who will have injections in a hotel room of a substance that they may not know. It's very important for us to know that. I personally don't inject fat into patients that have had previous gluteal injections because I'm very worried about them developing an infection. They're at a much higher risk of developing an infection, and I've seen some results that are absolutely catastrophic from that. So these types of things are very, very important to mention to your surgeon, even if you feel that you don't want to. Obviously, disclose any previous lipo or BBL surgery that you've had. Okay, so that deals with the consultation. And believe it or not, there's more things to go through with the consultation, but I'm going to stop there because I think I've kind of given you a good idea of how to prepare and things to do and how to have a successful consultation, but it's also an incredibly important step of this procedure, so it's good to be prepared. All right, now we're going to go and look 1 month before surgery. And some of this will be a little bit of a crossover from last night, but we'll look at what you need to be doing a month before surgery. And you'll notice I got the tote bag on there. Now, this is really where all of your preparation pays off. So if you've been preparing for a BBL for 2 or 3 months, or sometimes longer, sometimes patients will be aware they're having a BBL a year or even more in advance. Well, now within the last month before your surgery is where everything really pays off. All your preparation pays off. So you can do a lot of preparation, but in the last month, it's kind of time to execute the plan. So all of this beforehand was preparing, and then now it's time to okay, let's get things done. And so you're gonna wanna kind of go through a checklist and execute this plan. You're gonna stop smoking all recreational drugs, The smoking, it's not a deal breaker for having a BBL. You can smoke and have a BBL, but all your risks and complications are doubled by smoking. It interferes with wound healing. It interferes with fat survival. So it's very important, if you can stop smoking, to stop smoking. Now's the time to do it, 30 days before your surgery. That includes any vapes, patches, anything with nicotine in it. We want stopped. And stop any recreational drugs. We do test for recreational drugs prior to surgery with a urine test, and that could lead to a cancellation of surgery. It's okay to continue marijuana as long as you're doing it without using any nicotine. It's important to stop these medications. I'll go through them because we went through them last night, but Ozempic, that's one of the medications for weight loss that can delay your stomach from emptying, and that can be a problem with having surgery with having a full stomach. That's why we make sure that you don't eat or drink the night before surgery. You're going to stop the NSAIDs, which are all the things going to make you bleed, like aspirin and Aleve, etc. You're going to stop steroids. Remember, this has to be done under the direction of your physician. You're going to stop phentermine. Phentermine can excite your heart and make, give you an arrhythmia problem during surgery. You're going to stop your herbal supplements, your vitamin E. Don't take any cold medications. And if you can safely stop your oral contraceptives for a month before and a month after surgery, that will decrease your chance of developing a blood clot. You're going to continue all the usual medications that you take for all these medical problems, as well as asthma. Sometimes patients stop asthma medication, and we don't want that. Asthma can be a very difficult problem to treat in the operating room. And if you're, excuse me, if you're having problem breathing, then we can put a breathing tube. And that's what you have when you have a general anesthetic. We put a breathing tube in and we breathe for you. But the problem with asthma is that the airways get constricted. So we can put a breathing tube in, but then we just can't get that air to go in because it gets very tight. And so you can have a exacerbation. How do you say that? Anyway, you can have a flare-up of your asthma if you stop your medications, and so we don't want you to do that. So you must continue them. Bring your puffer, your inhaler with you on the day of surgery, because anesthesia will administer that during your operation as well through the breathing tube. We went over this before. I'm just going to run through it quickly. These are your essential items to purchase. And this is now 30 days before surgery. So if you haven't bought them before that 30-day mark, now is the time to do it. I recommend these items. I think they're essential. I think everyone should have them prior to going through a BBL. The OG Faja, lipoforms, foams, lipo boards, compression socks, the Chuck pads, which are those blue puppy pads, Pedialyte, the OG scar system, so you get a better scar after your surgery. You're going to need to take your iron, your folate, your vitamin C, disposable gloves for your caregiver. You're going to need gauze and ABD pads, an OG roller, which is what's going to help you get really good skin, the Fiber Guard, which is something that doesn't even exist yet, but it's being developed, and then a BBL pillow. The Fiber Guard is very cool. Okay, this is 30 days before surgery. You're going to get your labs completed. I'm not going to go through all of those. And then if you're traveling from out of town, there are quite a few details that you need to tie up. This is not all of them, but this is some major ones. So you're going to need to select your accommodation, whether you're going to stay in an Airbnb, in a hotel, in a recovery house. You need to sort of determine that, where you're going to pay attention to where the practice is located, where you're going to be having surgery, so it's in close proximity. You're going to select your flights. lining up your massages at home is very important, and lining up your massages to have in Miami, if you're having surgery here with me, is very important. But the bottom line is, if you're having massages in your hometown, line them up a month before surgery. We did recorded a podcast the other day, and with a certified lymphatic therapist, and she said, and I thought this was great advice, and I hadn't heard it before, go in and meet your massage therapist or your manual lymphatic drainage therapist before having surgery. And I thought that was a great idea. So you're not showing up all leaking and blood all over the faja and not in your right frame of mind, and then kind of saying, all right, now massage me. But you can have a consultation beforehand, so you meet the person, make sure that you're comfortable with them. Definitely, there's been lots of patients that have told me that I wasn't happy with my massages, or I had them in Miami, they were good, but I got home, they weren't very good. I thought she knew what she was doing, but it turns out she really didn't. And so I think seeing your therapist, if you can do that before you actually book them, I think that's a great idea. You may want to arrange a private nurse. It depends if that's something you're interested in. I do think that they're helpful, but I think that they're also helpful to give your caregiver a break, so that you don't necessarily have to have a nurse for 24/7, but you can have them for a few hours a day and to help your caregiver out. Find a manual lymphatic drainage person. They are not very common. There's not many of them, to be honest with you. We need a lot more. I wish we could have the genie clone them like they did with Frankie, but find one and make sure that they're a truly trained manual lymphatic drainage therapist, because people will say that they do that, but they're not necessarily trained in that. So I think that's important to do. We have I have an OG recovery protocol that I'm going to be giving out that has a lot of timelines in terms of when to wear foams and boards and those types of things. I'm going to be getting into that a little bit more in detail when we do the class in November, because that's going to be focused on sort of after surgery and then the recovery. But in general, since we're talking about the massages, you're going to want to get 10 massages over the first 2 weeks, which basically means one massage every day for the first week, and then one massage every other day for the second week. I recommend 5 manual lymphatic drainage in addition to those, and that's over the following 2 weeks. And that's where they're going to be working on getting that interstitial fluid with that very light pressure and that technique out of your body. So I said 5 manual lymphatic drainage massages. It could be 10, it could be 2. This is really dependent on your therapist, and they will do an evaluation and they will see, and also they teach you. And so if they feel comfortable after 3 sessions with them that you can do your own drainage and get rid of problems areas and all those types of things, then maybe you'll need less, but I would listen to them and determine how many you need. Okay, your tote. I love the tote. The tote and your caregiver, they're like neck and neck, number 1 and number 2. Like a 1A and 1B in my mind. Okay, so you're gonna pack your tote. It's a month before, but I liken it to having a baby. You kind of keep that duffel bag at the back door in case your water breaks or something happens, you got to get going. You don't have time to be packing everything. Well, do it ahead when you're having a BBL as well, just for peace of mind. And you can add to it during that month time. There's so many things that you really should carry in your tote. You may not need them all, but it's really nice to have these types of things. So I would have an extra faja. I talked about the Ziploc gallon bag, which I think is just a great idea for containing your soiled faja after your first massage, so you're not dripping it all over the place. Lip balm. You're going to have a dry mouth from having medications and everything else, so having some lip balm, having some hard candy. You could be not feeling well, you're nauseated, you need a little bit of sugar, you can have hard candy. If you're nauseated, you may throw up. You want to have something in your tote bag that can catch all of that. Disposable gloves, the Shiwi, which is that little device that you can use to pee standing up, so you don't have to sit down. Have some water, some baby wipes. There's a lot of stuff to put in your tote, and I wouldn't underestimate it, because that's just a nice little security blanket for you. You've got it. Everything's in there. And I joke about it, but I do talk to patients about it, and that's where I got the idea from. I didn't come up with this. I've not had a BBL. I've learned everything from patients. But when you see patients who are really organized, they'll tell you, like, oh no, I had a tote. I packed that a month beforehand, and they'll tell you what's in it, and it really makes sense because they use almost every item in there, and it's nice to have that. So the other thing you want to do at this time, as you get closer to surgery, is to take your own photos. Take your own before photos. And you can do them any way you want, but I would, our photos are medical standard, blue wall, naked, good light, front, side, back, those types of things. So you can take some of those. You can take them in clothes. You can take them in dresses, how you want to look after, you want to fill this, or any of those types of things. Make sure you have all angles covered, good light, and have somebody else do them for you if you can. Somebody that you're obviously comfortable with, take them, because selfies can be harder to compare to afterwards. And it's nice to have your own photos. We'll give you your own photos. I give patients, they're part of the medical record. You can have your photos beforehand. But it's nice to also have your own, because you're going to be in your own environment again, and it's nice to compare them. Talk with your caregiver. There is an OG caregiver instruction manual that is one of the actual PDF files tonight that will be given. It's kind of an instructional manual light, because there is a lot more things in there, but it's a really good starting point for you to get information on how to talk and prepare your caregiver. If you didn't attend the class last night, I really would urge you to watch the video from last night. There is a good section on caregiver. I think it's so important that you do that. But at this point, with the 30 days away from your surgery, it's good to really get down to the nitty-gritty and have some of those conversations that I was talking about. If you didn't see it, watch the video, because it's some good points that you need to do to prepare your caregiver. And now's the time, when you're a month out. You're not going to want to be doing this the day before surgery, a month out before surgery. Go through some of these points and discussions that you'll find in this manual to prepare your caregiver. Okay, now we're going to be talking sort of about the day of surgery, the night before, what to do, maybe a little bit after, kind of take you through some of these steps. So you've done all this preparation work, you've done everything for the month, and then now's the day. And what do you do the night before? So just some very practical things. You're going to want to remove piercings. Sometimes it's difficult for patients to remove a piercing. Sometimes they have to go to piercing shops. If you think it's going to be a problem, then don't leave it till the night before surgery. But you're going to remove any piercings the night before surgery for sure. Remove any jewelry, nail polish. Have some type of plan for hair control if you do have a lot of hair, because we don't want your hair to be contaminating the surgical field. So it needs to be put underneath some type of a, like cap. We'll give you a bonnet or sometimes two. But if you can control your hair preoperatively, if that's an issue, then come up with some type of plan. It's best to have it on top of your head, because you're going to be laying on the back of your head and you're going to be laid on the side. When you're laying on your tummy, your head is actually turned to the side and turned to the other side. So you don't really want anything coming out this way, and you don't want anything coming out the back. So just anything on top makes it very easy for you to lay down or be prone. So have some plan for your hair if that's an issue. Remove artificial lashes. Frankie always tells me, remove the artificial lashes or I'll do it for you, because you have to tape the eyes. It puts ointment in We want to make sure your eyes are protected during surgery and you don't get a corneal abrasion. I personally have had 3 corneal abrasions, not from surgery, but from one was when I was probably like 18 or 19 doing construction, and I was using a skill saw, and a little wood chip came up and hit me in the eye, and of course I wasn't wearing any safety glasses, and they are extremely painful. And so you want to make sure that, we want to make sure that that doesn't happen to you. So we do quite a bit of protection of the eyes during surgery. And when we do that, you'll lose your eyelashes. So I think it's better if you can take them off yourself, because then you really know where they're attached and what they're doing. And the night before surgery, double check the tote. Keep that tote on high level. Critical. No chuckling over there about that tote. Okay, and then the other thing to do the night before surgery, lay out your comfortable clothes. You're gonna wash your body with Hibiclens, which is a cleanser. It's actually what we use in the operating room as well to sterilize your skin. You're gonna use a washcloth and some Hibiclens and just take a shower, but be thorough in what you do in terms of wash everywhere with the Hibiclens. Don't shave the night before surgery. That's something we used to. When I did general surgery, we would actually shave the patients in the operating room. So if I was doing like say an inguinal hernia repair, somebody's a general surgeon, we would shave the inguinal region right before surgery. And then we realized, that increased risks of infection. So then we had patients do them at home, and then that turned out to increase risk of infection, where because you're cutting the skin, you're making little breaks in the skin. Even if you don't bleed from shaving, you get a little nick microscopically, and that could allow the bacteria to go in. So we don't like any shaving of the skin prior to surgery at all, and make sure you wash with the Hibiclens. You're going to organize your pain pills. You're going to have pain pills and antibiotics. Make sure you know where those are. They're organized. I think it's always a good idea to count the pain pills when you get them from the pharmacist, like right when you get them from the pharmacist, so you know that you were dispensed the correct amount. I have had patients over the years, return to me for a renewal of a prescription, and it's very early. I'm like, this doesn't make any sense at all. What happened to your pain pills? And they're like, well, when I opened my bottle, there were like 6 pills. And so, I've had instances where family members have been taking the pills and things like that. So organize them, count them, lay them out. I think a little chart is helpful to have that your caregiver, you can evolve them into make that so they can log and record what you took when you took them. Then sometimes people stop their iron and folate and vitamin C. You don't need to. It's better if you continue that, so you can take that the night before surgery. And then get the car organized, and you can do that with your caregiver. You're going to need to have a little bed to lay on. Make sure you know how the seat belts work, and when you're in that position, so that you can travel safely. So put some pads there, some old towels, and something for potential vomiting. It's not super common, but definitely can happen. So it's nice to have something ready, available. Update your emergency contact information so that you can give that to the nurse or whoever in whatever office you go to that takes that information. You want to make sure that's up to date. Get your transportation all ready. Confirm your travel time and departure. I think it's a good idea. Just throw it in Waze. So I've got to be there at 6 in the morning. How long will that take? And give yourself 30 minutes of extra time, just so that you're not, if there's an accident or something, it's not going to put you off. Because all of these things that you're doing the night before surgery should be there to relieve anxiety. There is anxiety associated with having surgery. People don't have surgery every day, and sometimes they've never had surgery, and people are worried about anesthesia. They're worried about the postoperative pain. They're worried about never waking up. They're worried about all these types of things. So try to get whatever you can control under control. So if that means I got my tote packed. I know that's good to go. I got my car packed. It's full of gas. I know where I'm going to be, the address. I got my contact information. If somebody has to get a hold of someone, your caregiver should have that information. Do whatever you can to take care of all these little details so that when you go to sleep, you're like as relaxed as you can be. You're going to be nervous still, but you'll be as relaxed as you can be because you're not worrying about these other things on your mind. So we're trying to decrease the anxiety. We know that patients that are warmer before surgery, that are calmer before surgery, do have a better recovery. And that you can even see it in the recovery room. If somebody comes in, they're really wound up. They tend to be wound up when they wake up, and I think it can hurt their recovery. So taking care of these things, it may seem kind of trivial, like, oh God, I gotta type this into Waze, like what's this guy's problem? But I think those things are meant to purposefully be done to relieve anxiety. If you can clear your head before you go to sleep knowing that everything's done, then it's going to make things much smoother for you. Obviously, you're not going to eat or drink after midnight before surgery. The day of your surgery, time to be as relaxed as possible. There are deep breathing exercises and things that you can do. Make sure that you've got nice warm clothes. Most of the operating rooms or clinics or offices or hospitals are cold. And so having nice warm clothes, you're going to be wearing compression socks. I think it's a good idea to put like a little fuzzy or woolly pair of socks over top of the compression socks to keep your feet warm. You're going to then go, when you arrive, you meet the nurse and you're chained. This is sort of a general idea of what happens for everyone. You'll meet anesthesia. They kind of come in, they make you open your mouth. They're looking to assess your airway. They'll look at your jaw, ask you if you had any neck problems, all that type of stuff. They're just basically wanting to make sure that your airway is going to be a easy airway to intubate. And if it's not, then there are other steps that they have to take to secure their airway. And they'll start the IV. You'll have photo, surgical marking, and then you, depending where you are, but usually most of the plastic surgery offices, you'll just walk into the operating room. And then right after your surgery, you'll wake up in the operating room, but you actually won't be aware of that. So people think that they wake up in the recovery room. Most people don't say anything badly. I think people worry that what are they going to say when they go to sleep. You go to sleep so quickly once that medication is administered that patients don't even have time to say anything. So don't be concerned you're going to say something embarrassing when you go to sleep or when you wake up. That's usually not the case. And then when you're in the recovery room, you'll be discharged home once those discharge criteria are met, which are really related to your comfort and your vital signs. So I've got a checklist here that I'm just going to kind of go through. I included it here. It's repeated some of the things that I've said already, but I think it would be nice just to have it here on the video that you could pause and look for, and we're going to be disseminating this at some point as well in a checklist. So I'm just going to ramble through this, and then after this we'll be able to get to questions, and we should have quite a bit more time tonight than we did yesterday. Do not eat or drink anything 8 hours prior to surgery. Continue to take your medications as prescribed with a sip of water, so that's safe to do on your day of surgery. If you always take your antihypertensive medicine at 6 in the morning, then take it at 6 in the morning on the day of surgery. Just with a little sip of water is safe. You can continue to take your iron, folic acid, and vitamin C. I recommend you do that when you get home with some food, wear your comfortable clothes. They should all be buttoned up in the front, so it's very easy for your nurse to place them, and you're not having to stretch and move and do all these types of things. Comfortable shoes. I would say most people show up in Croc or Birkenstock or something like that. Then you're going to meet with the surgeon. You're going to get your preoperative markings and photos. You'll walk into the operating room. You'll wake up in the recovery room. You already have your faja in place. We put it on when you sleep, before you wake up. It is very common to feel cold because with this operation, it's very hard to keep patients warm. We do have warming devices where the fluid is warmed that goes into your body, and it's kept at a warm temperature, and there's a basically a hot water sort of thermal blanket to keep your body warm. But still, it's a very open operation. We're doing lipo all over, and we're turning you, injecting, and so it's common to feel cold and even have shivering right away when we go to recovery. And every recovery room's this way. Is that there are warm blankets and warming devices. We call them bear huggers. They basically blow hot air, and they'll help you to get warm, but they do take a little minute to work. So you may feel cold and have that shivering. I think it's good to know beforehand because patients can be a little bit put off by it. And even patients that are totally normal temperature can feel shivering just from the anesthetic and really sort of have like a type feeling. Some patients will feel the need to urinate afterwards, but usually there's a catheter in your bladder, and we remove that in recovery. You don't really notice it being removed, but once in a while somebody really gets an urgency to pee, and it's kind of a difficult conversation because you're like, it's okay, you can pee. It's like, I gotta pee. You can pee. I gotta get up to the bathroom. You get a catheter. So it's good to kind of be aware that's a possibility if that happens to you, but it usually doesn't, and patients the catheter drains the bladder. They don't have to do anything, and then the catheter gets removed before you go home, and it's not painful at all. Patients will stay, that should be recovery room, stay in the recovery room for 1 or 2 hours. Some patients stay longer, but I would say 1 hour is usually the minimum until patients are alert, awake, and meet those discharge criteria. When you get home, you're going to have a small amount of food, and then you're going to take your pain medication. In terms of diet, eat whatever you like. There's some patients that feel like something heavier. Some patients feel like soup. It's whatever you kind of feel like. I don't feel strongly one way or the other. And then probably an hour after you take your pain medication, you'll take your antibiotic as well, and just follow the instructions on the bottle. You're not going to sit on your butt after having a BBL. You're going to lay on your tummy. I don't like patients laying on either side because there's also fat grafted into that area. So you're going to lay on your tummy. That's why it's important to build your nest beforehand. So caregiver tote bag nest. So nest is very important. You're going to have some place where you're going to recover. Lay down there. Feel what it's like. Remember last night, if you were there, I was talking about some wedges, some pillows, some things to help position you. Get into a few different positions because you're not going to want to stay in the exact same position every time. So have a few different things so that you can kind of get comfortable. Put the TV on and see what it's like to watch TV from that angle. You may have to adjust your TV. You're going to walk every hour while awake for a very short distance and increasing that distance every day. Drink plenty of water and Pedialyte. That's what I recommend as a hydration solution. And very importantly, you're going to stay in your faja and do not remove the faja. The faja is, you're going to be leaking, and that's why you put the chuck pads down, the dirty towels and things. But the faja is going to be providing compression, and that's like putting your hand on something that's bleeding. I mean, that's how we stop bleeding if we're not doing something, tying it off or using cautery or something. It's just simple pressure. So that's what your faja is doing for you, is it's putting pressure on, not to try to get you the smallest waist possible. It's putting pressure on so that you're stopping the bleeding. And so you got to stay in your faja in order to make sure that you minimize the amount of bleeding that you have after surgery. Sleep on your tummy, obviously. Don't get up and walk around or use the bathroom without assistance. You're going to be on narcotics. You're going to have a quick heart rate. You may be a little woozy. Don't do anything without assistance. Even if you feel like it during that, at least the first 48 hours, have somebody with you all the time. You should have my dog because he's with me like all the time. You may eat anything that you want, but I always recommend like a high fiber diet because constipation can be a problem from the anesthetic and be a problem from the narcotics. So a lot of vegetables, talked about Metamucil, eating an apple I think is very good. If you can do that preferably at the same time every day, that will help give your body that fiber bolus. And expect a lot of drainage in the first 48 hours, particularly the first 24 hours. It's going to be blood tinge, which is normal. I have seen patients, post on social media. I haven't seen it as much recently, but maybe a few years ago, where people will take photos of their faja and they'll be like, I can't believe they left me this way. And I'll be like, yeah, that's normal. It's like, it's messy. It's very messy. And so you'll see, and it looks very dramatic, the blood in the faja too, because blood is like food coloring. So just a small little drop makes a big impact. And so expect a lot of drainage for those 24, 48 hours. That's why you're going to be prepared with your puppy pee pads and your towels and things like that. So that's normal to be expected. So that's a lot of it. We're doing okay on time, and right now I think would be a good time that I can take any questions that we're going to have. I do want to tell you about one of the PDFs. I think I'll do that now. So you're going to get the caregiver instructions that I mentioned. That's a downloadable link, and then there's also a downloadable link to this chart, which I'm really happy with, and Gabby and Manuel did a lot of work putting this chart together because it's a little harder than it looks. But this chart is really cool. This is a BBL surgery roadmap. So you start here, and it's got everything, and this is really kind of a lot of the things that I've talked about where you're considering a BBL. Obviously, it's very abbreviated, so I can get all the information in here, but this is all the information, and you take your little path and you drive down the road. There's a little area here where, so that was the foreshadowing with that little me with the OG, the little mechanic, because this is what we call the complication road. So don't worry, because we can fix it, and we're going to get you back on the main road. That's how I consider these complications, is we'll get you back onto the I-95 or the I-5 or wherever you live, but you may take a little detour. And so this is complication alley. Hopefully that doesn't happen to you and you just keep on rolling by. Then it has a list of complications and how they're treated and everything all the way to the finish line, which is the 1 year mark. So this is a abbreviated version of the course that we're going to be giving, and today we've given sort of the first, or today and last night we've given that first part, and then the rest of the journey will be given in November. But if you're interested in getting this, you can download this, you can print it out. It's just the same size as two pieces of paper, so it's easy to carry. You can stick this on your fridge, however you want to do it, and I think it's awesome. So I thank Gabby and Manuel for putting that together, and the three of us worked to kind of fit everything in there. It's really good. So that's available, and so check that out. I'm gonna move, get into a more comfy chair, take my water, and questions. Are we good? We're ready for questions? I'm gonna read them off this board. Okay. On the move. On the move. we're in a reasonable amount of time. So I'm just waiting for the questions to come up here. This is fun, by the way. I really like this format of presenting this material, because I feel that when I'm doing a regular video, I'm pressed for time, and in this type of situation, then I can spend a little bit more time and go into some of the things in detail. And it's not during the day. I don't have any surgeries, etc. So, okay, let's see. Subscribe to my channel, it says, but I think that's from us. Okay, am I just going to start at the top there and roll down? Is that how it works? Then you guys are going to scroll?
Yes.
Okay. All right. What if you haven't had an asthma attack for 5 years? You probably don't have asthma, I would guess, and I would see your family doctor or your pulmonologist. There's testing that can be done to see if you have asthma, but if you haven't had an attack for 5 years, I would doubt that you have it. But I don't know you. I'm a plastic surgeon. I'm not a pulmonologist, so talk to your family doctor. But clear that up. It's important. Let me answer another question that nobody asked me, but it's something that's not talked about very often, and that is penicillin allergies are super common, but in reality, they're not really that common. People say they have a penicillin allergy, but it's really they've had a rash as a child and their parent told them, hey, don't take penicillin anymore, or their doctor told them that. So you can get checked to see if you have a penicillin allergy, and you can actually get treated and desensitized with an immunologist. And so if that's something that is worthwhile doing. So I think sometimes these problems come up. We notice them when people are getting ready for plastic surgery. Sometimes pick up diabetes, sometimes thyroid problems. If you've had asthma, but you're not sure whether you have it anymore, see your doctor and get checked. And you can do the same thing with penicillin allergy. You really don't want to be walking around with the label of a penicillin allergy if you truly don't have it, because there's a lot of penicillins to take, and then there are even more penicillin-like drugs that cross-react with penicillin, and you can be ruling out like 30, 40, 50 different antibiotics, and you don't want to limit yourself, especially with today. Okay. Is there any way to stop it moving or not? What am I doing? Oh, read it there. Okay, sorry. Can patient use an air mattress instead of the buttocks pillows? So during the first 2 weeks, I don't want you sitting or putting any pressure on your butt at all. And then when we use the BBL pillow, that's at the 2-week mark, and that goes under your leg. So I don't think that an air mattress would really necessarily fulfill that. Can you still take intramuscular injections in the butt after BBL? Yeah, I don't know exactly what medication you're talking about, but if you're talking about a vaccine or an antibiotic, then yes, it's still safe, because remember, after you've had a BBL, it's your fat. And so it's no different than where you are now. It has a different shape, has a different volume, but it's still, when you do an intramuscular injection in the butt, you're just going through that fat and putting it in the muscle, so there wouldn't be any problem having a shot after having a BBL. What is the Cell Saver? So Cell Saver is a device that we run the liquid that we've separated from the fat that contains the blood and the fluid that we put in, and that gets run through, and the fluid that we put in gets filtered out, and it just saves the red blood cells, and then we give those red blood cells back to you. It's sort of like giving yourself a blood transfusion. We're using your blood, transfusing it back to you, and it's basically giving you a unit of blood afterwards, so it's very helpful. Do I have a preference between file colors? No, I don't. How long to stay in Miami if coming from Europe and does a long flight? I do think it makes a difference. We do operate on quite a few patients from overseas, and typically they'll spend 2 weeks here. Usually, if you're traveling for the United States, it's 1 week. But I do think just because of longer flight, and let's say you're having a tummy tuck or something, we want to make sure the drains are out, and we want to kind of get everything 100% before you go back home. So if you can spend 2 weeks, I think that would be ideal. When can we change the first faja? Well, so I don't know if you mean going to a stage 2 or not. But usually what happens is you'll have surgery, we'll put you in the faja, you're going to stay in that faja until the next day. You're going to go in, remove the faja, have your massage, get cleaned up, and then put a new faja on. That's what I always say, get 2 fajas, one to wear, one to wash. If you're talking about a stage 2, I don't really believe in stage 2. I think stage 2 was something developed to sell more fajas. I don't have a stage 2 faja because I just fundamentally don't believe in it. The faja the OG faja is a tight compressive garment. Anything tighter than that is not going to give you a better result. If you want to see, there's a video on my YouTube channel about waist trainers, and the whole concept that you can wear something smaller around your waist and then you're going to take it off and your body's going to stay like that is just false. And so it's the same way with the stage 2 faja. I don't think you need one. You just get your first faja altered so that your faja always remains snug, but it has to be comfortable, good compression, but snug. And then if you need a stage 2, then just buy a smaller faja. Just go down in size. So I don't think you need that. I have a tummy tuck BBL scheduled in April. Would I need a faja or a binder at first? So that's a good question, and I haven't really talked about that or addressed that. But what I don't want somebody getting in a faja right after a tummy tuck. I know some surgeons do it, so that we're all different. But I think there's too much pressure from a faja on the abdominal flap, and you can have tissue necrosis. It can die. I've certainly seen that more than once. And I think the faja can disrupt the suture line. So I don't like my patients to get into a faja after a tummy tuck until 2 weeks after surgery. We use a binder, but again, it's really just for some feeling of security and comfort. It's not trying to squeeze everything in. You're not going to squeeze your way to a good result. If you're not getting a good result in the operating room, you're not going to make that up with some type of extra strong compression device. Most of the time where patients are not happy after having a tummy tuck because of swelling, it's usually because of internal fat. And so a waist trainer is not really going to help you. Losing the weight will help you get a smaller, flatter stomach. So just to clarify that, then you're going to be in a binder for, I don't even recommend wearing the binder for more than a week anyway. And then at 2 weeks, put the faja on. Can a person get a breast reduction? Do I need to read these questions? Everyone can see them, right? Okay. The answer to that is no. You can have a breast augmentation with a BBL because you can sleep on your tummy after having a breast augmentation. But if you have a lift, we're changing the blood supply to the nipple and the areola. So we don't want you to put any pressure on that. It's a much different scar than it is from breast augmentation. So I do not combine a BBL with a breast lift. I don't combine it with a breast lift, with breast reduction, breast lift with implant. It's all basically the same operation. I do combine a BBL with a breast augmentation. How soon can I get iron IV? I don't know. I mean, you really shouldn't be in a situation where you need that. Your iron IV should be done before surgery with a hematologist and your primary care doctor, usually like a month or 2 months before surgery, to build up your iron stores. It takes a long time to build up your iron stores. So I wouldn't really plan on having an IV iron injection after surgery. unless your stores were severely depleted, but that would be very uncommon. All of that usually happens before surgery. I would say a week. I would say a 10. Well, let me take that back. Men would say a 10. I think women, they always, if they've had children, they always kind of leave the 10 for the pregnancy, the birth, but and then they'll put it at maybe an 8 or 9. But it's painful. The pain comes from both. Sometimes people tell me their BBL, the injection was fine, and sometimes people tell me the lipo was really the problem, and other people told me, oh no, my lipo wasn't a problem, it was the butt. I think that has to do with the distensibility of your tissue, because if your tissue is not really moving very well and it's hard to get the fat in, I fill people up with fat and try to get as much projection as I can, particularly if somebody has not very distensible tissue. And so that feels a little bit tighter. I use the ultrasound and I look to see where there are little areas where I could put more fat in patients that I'm having a problem getting that projection. And so I do think in those patients, they probably hurt more in their gluteal area than they do from the liposuction. No, FibroGuard is I'm hoping to get that out by Christmas. It's going to be great. It's so cool. There's nothing out there like it. You do wear a, that question just popped up. What was it? It was, do you have that last one? Okay, so I'll answer this question. Maybe we'll come back to the other one. So that's a very good question. I don't know the answer to that. I think that I do BBLs and tummy tucks together at the same time. People seem to recover fine. But I don't know how they sleep. It's difficult. I know some people sleep in an anti-gravity chair. Some people sleep on their knees. I really don't have the answer for that, because with a tummy tuck, you can't sleep on your tummy. With a BBL, you have to sleep on your tummy. You can't sleep on your back, and you can't lay on your sides with a BBL. So it does become problematic. People do it. They recover. I usually recommend you do a tummy tuck, and then 6 months later do a BBL. You'll still have plenty of fat, because when we do a tummy tuck, we're just removing this skin here and doing a little bit of lipo in the upper part of the abdomen, but it leaves all the other areas of fat available still. Your whole back, all your sides, your flanks, a key area, all that fat is available. So it's totally possible and easy to do a BBL after having a tummy tuck. So I think it's a difficult recovery to do them together. So I usually recommend do a tummy 2, which is just 2 areas of lipo, and then 6 months later come and do your BBL. That way I can also lipo the front of your abdomen much more thoroughly than I can when I do a tummy tuck, because I have to be a little bit careful of the blood supply. So, okay, so good question. What are the areas included with Lipo 360? So Lipo 360 is kind of, imagine from your bra line all the way down to your panty line in the front. If you want to add your mons, that's an extra area that would be below the panty line. But if we're talking Lipo 360 or what we call Lipo 12 areas, it's going to be from your bra line all the way down to your panty line in the front, all the way around your body, and then your full back, including up high in the back, all the way down through your mid back, your lower back, in through that key area, and then, wrapping around the sides. It gets all of this area on the lateral side of your chest. It does not include arms. It does not include chin. It does not include inner thigh. It does not include mons. It does not include lipo here. I don't lipo here very often. People ask me to do it frequently. I used to do it, 10 years ago on everyone, but it's not that effective, because most of the time what you have here is skin that you need for arm excursion. So most of that is skin, and if you have a real protuberance there, it's usually breast tissue and not fat, which can't be lipoed either. No, I don't have any plans of using J plasma. I'm not a strong believer in it. I know that other people are. I don't particularly like things that use thermal energy. I've seen patients with pretty bad fibrosis from liposuction techniques where they're using thermal energy because it heats the tissue, and I think it produces more scarring and more fibrosis, and that is like the number one enemy of liposuction, so I don't like to do that. J plasma, I first used J plasma when I was a general surgery resident. Was probably back in like the 98 or 99 or something like that. It wasn't necessarily called that, but we were using it to operate on the liver. And it was a helium based to stop bleeding in the liver. And there are technologies that I've seen throughout my career where they may not work in one arena, but there's been a lot of development and a lot of financial investment, and so they look for another area where it can be applied. I'm not saying that's what's happened with J plasma, but sometimes you're looking for a use for your product, and I'm not really thrilled with it, so I don't use it. I know other people use it, have great results with it. I leave that up to them. I don't do the high definition lipo. That is very popular now, and people tell me you need to do it. I think there are some surgeons do some remarkable jobs with high definition and using these types of techniques, but I think it's for very specific people that have very, very low, they're very lean, because I think sometimes you can create a high definition set of abs in somebody that's otherwise low definition. And so to me, it kind of looks a little bit odd. You see somebody walking out of the water or the ocean or something, and they're taking these photos, and they've got these abs, but then their legs, their arms, their chest, their face, nothing really matches. It's not like they're a real hardcore ultra marathoner and then they've got this six pack. So I kind of steer clear of that. I wonder how those abs will look in 20 years when the skin descends and there's a lot of permanent scarring that comes from it. And so I personally don't do that. Add more fat on the thigh. I mean, I graft into the thighs as part of my BBL when I'm working in the hips and the butt. Everything is trying to blend it together because I'm just following that OG line. So I don't graft fat into the anterior thigh, into the front thigh. I graft it into the lateral thigh and into the back if needed to blend everything. To me, everything is about blending because I like things to look natural and everything to kind of match and work together. I mean, I don't inject. If somebody has Sculptra, I won't inject because it's a foreign body. The reason why foreign bodies are dangerous from an infection point of view is they can get contaminated with bacteria, and the bacteria can proliferate there, and then you can get really a bad infection. And there are people that certainly had necrotizing fasciitis, which is the flesh-eating disease from having fat injected into areas of foreign body. So I consider Sculptra to be a foreign body, and I wouldn't inject in somebody that had Sculptra. I don't inject in anybody that's had anything. I'm pretty cautious in that regard. I just don't see the need to take on that risk and potentially harm someone that way. I'm sure I have injected in areas that people have had shots because not everyone is forthcoming with having that, and I haven't had any problems, but I don't see myself going down that road. You'd have to tell me what way you're using the collagen, and I don't know if you mean injection or consuming it, eating it, so I'm not sure how to answer that question. I don't know what's in CMOS, and so I tell patients to stop all herbal supplements 1 month before surgery. It could be totally fine to take it every day throughout, and including on the day of surgery and after surgery and everything else. I just don't know what's in it, and compared to a medication that's regulated by the FDA where we know exactly what's in the medication, we know the dose, and we know the side effects. It's been studied, there's been clinical trials, all of these things have been worked out. That's easy for me to give advice. On supplements, I really don't know what's in them, what the active ingredient, if they can contribute to bleeding or heart or any problems. So I just unilaterally say, if you're taking a supplement, just take a break for 1 month before surgery. I would say it's safe if you have sciatic nerve pain. It could make your recovery more difficult. I'd want to make sure you, if you can, get that treated or corrected beforehand. But there's nothing that's going to be done with your BBL that should cause you any problems with your sciatic nerve. It may flare up your back pain, which may flare up some sciatic nerve pain just because of your positioning, having to lay on your tummy. So I would kind of figure that out beforehand with your spine surgeon, a neurosurgeon, a neurologist, or family doctor, whoever's kind of helping you with that, and try and figure that out. And then try yourself to see if you can tolerate laying on your tummy for prolonged periods of time, because that's probably, the surgery itself is not going to bother the sciatic nerve. We don't get near the sciatic nerve, but the recovery may bother, but you'd have to kind of work that out yourself to see if that would be an issue for you. I do mini tummy tucks, but there's just not many people that are good candidates for mini tummy tucks. But a good candidate is somebody who has just a small roll on the lower part of the abdomen that we can just remove that, and then we don't touch the belly button. So sometimes after lipo, I'll do that with patients that have a little bit of loose skin there and they don't have enough for a full tummy tuck, so I'll just do like a little mini there. But I don't do many because there are just not many good candidates out there. That's just surgical preference. I leave my incisions open to drain. I used to use drains a long time ago. I think the results are the same whether you use a drain or not. And the drains are also kind of hard on those incisions because they sort of torque around that incision. They tend to widen and make the incisions into more of a circle and rather than an ellipse. And we know that in an ellipse, a linear incision heals better and scars better than if you've got something that really gets widened and bigger. So I just don't see the need to use them. But some surgeons use them, and it's just preference. A lot of these things are just based on experience and what you do. And some people can say like, "Oh my God, I use a drain every time. I don't know how you do it without a drain." But for me, I stopped using drains and I haven't had any problems. Well, breast cancer is really not just one cancer. There's multiple different types of breast cancer, and so it's hard to exactly say, but usually if you have any type of cancer, if you've been cancer-free for 5 years, you're considered cured of that cancer. You don't have to wait 5 years, but I would talk to your oncologist and your family doctor, and my concern would be that you were healthy enough. So if you just had a lumpectomy and some radiation to your breast, you may recover and be in good shape to have a BBL sooner than if somebody gets chemotherapy or has axillary lymph nodes or some of these things that can impact your nutrition. So I would just say when you're back healthy and all of your blood counts are good and your albumin and your protein, all those things are good, and you're feeling good, then it's fine. It's safe to have a BBL. I don't. I've used Exparel. I mean, I was trained and used Exparel many years ago. I mean, I was still at Duke, so that would have been in before 2007 when Exparel came out. It's a fantastic drug. What it is it's a local anesthetic. It's bupivacaine. There's a whole bunch of different types of local anesthetics. They all have different onsets of action. So some work very quickly, and some take longer to start to work. So, and then some last longer and some act shorter. So I use lidocaine when I perform my liposuction, which is kind of the standard original fluid that was described by Dr. Klein, where we use lidocaine and your body's physiologic with fluid and epinephrine to stop you from bleeding. But the problem is if you use lidocaine at the same time that you use Exparel, Exparel is bupivacaine, but it has these little lysosomal, which are just like little fat kind of, they're little micelles, they're little, you know those little things that go like this? What are those things, those little models? I don't know, they're little toys, they're kind of multicolored and they go like that. So that's kind of what Exparel is. It's bupivacaine in the middle and it's surrounded by this fatty area, and so what happens is it takes longer for that bupivacaine to leak out, and so you get a longer amount of pain control. So it's fantastic. The problem is if you use it with lidocaine, then the lidocaine likes to bind to that little fatty thing that the bupivacaine is, and then you can get an overdose and die of lidocaine toxicity. So that's why I don't use Exparel with my liposuction. If I was just doing a plain tummy tuck, no lipo, then it would be safe, and that's when I would use Exparel. So I don't do any third round liposuction, and because there's just too much scar tissue, it's difficult to do a second round of lipo because of the scarring that's there, and it's almost impossible to do a third round, and it can become dangerous because as you're moving your cannula, remember to do the liposuction, you're taking a little cannula, it's like the size of a pencil, and you're passing that underneath the skin in the fatty layer. And when you have scar tissue that builds up, so this shrinks down because the fat goes, and the scar tissue, it can be very difficult. It's almost like trying to get a cannula through a rock. And you can have a higher incidence of having problems where that cannula can't go through, and you're having to use more force to try to get it through, and you can have a puncture. You can go intra-abdominal. So I don't think it's safe to perform a third round liposuction. I don't think it's that beneficial because most of the fat has been removed with the first two rounds, and most of what you're dealing with is residual scar tissue. So it's very difficult to perform. You don't really garner much fat, and it potentially dangerous. So I personally don't do a third round. So keloids and hypertrophic scars are problematic. If you have one in your body, then you are, if you've got one, I don't know, let's say at the back of your head or behind your ear, then you're more likely to develop another keloid with another incision. The places that form the least likely chance of developing a keloid are in the face and in the breast. The worst areas tend to be the shoulder, what we call high tension areas, the shoulder, the upper chest, the back. Then legs can be a problem with keloids. So if you have one, you're more likely to develop another one. Doesn't mean 100% chance you're going to, but if that's the case, usually what we'll do is we will inject some steroid either at the time of surgery or fairly close post-operatively to help minimize the chance of you developing that. And then to use silicone and silicone massage with scar gel can also decrease your chances. Yes, you can. If your skin is mobile and soft enough that it can move. So technically it can be done, and I've done it many times. And sometimes I've had patients come in and they have some loose extra skin, but you can really get a sense that nothing's going to move. And so, I don't want to make an incision, try to lift everything up, and then nothing moves because of the previous scarring. And so for some people that have bad fibrosis, even if they have some extra skin, it can rule them out as being a candidate for a tummy tuck, because that tissue just won't move. And you have to be able to lift up the tissue, and you have to be able to pull it down. It has to stretch a little bit in order to do a tummy tuck. How soon do you get massages? The next day. It's tummy 10 is like lipo 360. So you're going to get a massage the next day after having lipo. You're not going to massage the abdomen, but you're going to massage the other parts where you had lipo. You can be a safe candidate for a BBL as long as your seizures are controlled, and you would need clearance from your neurologist to say, yes, some so-and-so hasn't had a seizure within the last 12 months and is taking this medication and the levels are good and they're compliant with the medication, then it's safe to do BBL. That's not an uncommon scenario. I would say no, that's not normal, but it can happen. That's a complication. You can have, it depends on where you have the numbness and tingling. There's three main nerves that go to operate your hand: your radial nerve, your ulnar nerve, and your median nerve. And they run in these directions. The median nerve, this is the hand. I had carpal tunnel release here. You probably can't see the scar. I had a carpal, I feel like a weatherman. This is like Michigan. Oh, that's Michigan. It's like, it's going to be cold up. It's going to be cold up in the thumb today, heavy snow. But anyway, there's a scar here. This is where the median nerve is. So, and the ulnar nerve will give you numbness on the baby finger and half of your ring finger. And the median nerve will give you numbness on the rest of your fingers. And what can happen if after, not just lipo or BBL, but after any type of surgery, if you've had some compression of that nerve during your positioning, is we're very careful when we're moving people to try to make sure their hands are in a normal position, in a neutral position, so we're not adding pressure to that nerve. But you can, and the ulnar nerve can be compressed here. That's your funny bone. In that little ulnar groove, the ulnar nerve runs right there in that little, it's called the occipital groove. I think that's what it's called. And then it's right in there, and you can have pressure there from when if you're not padded properly during your surgery. So you can have pressure of the nerve, which can give you numbness, and then it can get worse with swelling. And so that can increase the amount of numbness and tingling you have. It usually goes away. I don't think I've ever seen anybody with permanent numbness and tingling in their hands, but it's worth mentioning it to your surgeon and having them look at it. I don't know, you just sit down and go. No, I don't know why do I say things like that? But it is a serious problem, actually, because I mentioned yesterday that constipation can really become a problem for recovery, where patients are kind of ready to go and everything's feeling good, but they're constipated. So the best way to treat constipation is to do it before it's a problem. And so if you know that's a problem for you, then I would get on like a daily Metamucil and drink that with two cups of water, and have apple, raspberry, high fiber. Raspberry is the highest fruit, highest fiber content, whatever, highest fruit with. It's got a lot of fiber in it. So you're going to want to eat like maybe a tray of raspberries every day, a week or two before your surgery, to get all of that fiber. But the real solution to constipation is fiber. Laxatives are sort of a last resort. You can use enemas. Those are a last resort. I would prefer that than using a stimulant like a laxative. That's because I just trained as a general surgeon. So we always try to use bulking agents to help with moving your bowels. So if that's a problem for you, I would really get into the Metamucil. It doesn't really matter how long you've had diastasis. Diastasis is pretty easy to repair. So you can't fix hip dips without a BBL because that's transferring fat, and anytime you transfer fat, that's considered a BBL. And I think all of these operations, tummy tuck, lipo, or BBL, from what patients have told me, is more painful than a C-section. I can remember somebody telling me, like, you were wrong, my C-section hurt way more. But in general, I can say that patients tell me that these operations are more painful than having a C-section. So I've got an exercise program out for BBLs, which is really good. I think it's kind of underutilized. It's by a exercise guru, John Sinclair, who came up with the system. The two of us sat down and went over things, and it's a really good system. So I would refer you to that. There's a video on it, and I think there's a PDF somewhere floating around about it. There's a lot of PDFs coming out from this, because I'm trying to disseminate this information the best way that I can. And video is not always the best. Sometimes it's better just to have it and read it. So anyway, there is an exercise program. In terms of when you do it, I usually tell people they can go at 3 weeks and work out as hard as they like. But there are patients that will work out much earlier than that, and I'm fine with that. I think as long as you feel comfortable, when you feel that you can resume exercise and want to start taking it up, I don't have any restriction on you for that. I think exercise is great, and it'll help your recovery. I really can't answer that question because I don't know what result you're looking for. I only plan on doing one round of BBL. Certainly I do round 2 BBLs, sometimes in my own patients, most commonly in other patients. So I really consider doing it one time and being done. That's so nice, thank you. I mean, tummy tucks, I would say 18 and above is fine. Can I have, if I don't plan to have like children next 5 years? Yeah, so here's the way it works with tummy tucks. So let's say you've had 3 kids and you're not planning on having any more kids. You're 6 months out from having your children. You've lost all of the weight that you gained with the pregnancy. Then you go ahead, you have your tummy tuck. Let's say you're 2 kids in, you've got some excess skin, you'd like a tummy tuck, but maybe next February you're planning on having a child. Just wait until you've had your child and then get the tummy tuck after that, because there's no point, if you know you're going to have children soon, of going through doing the tummy tuck and then having a child and stretching things again. It's not as bad as we used to think about having a child after having a tummy tuck. Some people really don't look that much different, but it just intuitively doesn't make sense. If you're planning on doing something or having a child, just wait another year or 2 to have your tummy tuck. But if you're 18 and you had a child when you were 14 or 15, maybe you were heavier as a teenager and you've lost a lot of weight, or you've had gastric bypass when you were 17 and now you're 18 and you want to have a tummy tuck because you've got this excess skin. It can be quite limiting for patients, or embarrassing, or a lot of different reasons for wanting to get a tummy tuck. but you're planning on having kids in the future, but you're 18, you're like, I may not have kids until I'm 28. So I think it's fine to go through at that point and say, yeah, sure, I understand. You want to look good where you are now, and you don't want to wait until you have children. You don't even know if you're going to have children again, whatever the situation it is. Then I think that's fine to have a tummy tuck at 18 under those reasons. So I would say 18 and above, and it just kind of depends where you are in that whole scenario. I mean, I don't have any other techniques. I've given you everything I've got for the last almost 4 hours here, so I'm not keeping anything back. You wake up on your back, because so you have to remember that with anesthesia, everything is related to, anesthesia says ABC, airway, breathing, circulation, or as surgeons say about anesthesia, all about the chairs, because they're sitting all day. But so airway, it's the most important thing is to maintain your airway and to make sure that it's safe and that you're breathing and that they're controlling it. So when they remove the breathing tube, you're going to be laying on your back and they're going to be over you and they're going to be managing your airway. It would not be safe if you're laying on your tummy to remove the tube. I mean, there are certain surgeries where they do that in very special situations, but by and large, everyone gets extubated after surgery laying on their back for airway safety reasons. And you go to the recovery room on your back for that reason as well, so that we maintain your airway. If you were to vomit, for example, we need to immediately suction that fluid out and tend to your airway. And so we wait until patients are recovered enough, they're breathing fine, we're no longer concerned about their airway before we flip them over onto their tummy in recovery. That's kind of a big topic. I'm going to save that question for another day, because there's really a lot to talk about with that. Please answer me. All right, Chantel, what do you got? Will the BBL pillow get flat after sitting on it long periods of time? No, it doesn't. You know why? Because they're hard. They're actually pretty uncomfortable, I would say. They're like hard bricks. So they're not the type of thing where you really just compress down to a pancake. People tell me that it feels like, you know, those old corsets, you see those movies where, you know, they're usually British movies where some lady princess or something is getting dressed with her servants are helping her, and they wear the corset and they pull that really tight to cinch her waist in and impair her breathing. People tell me that's how diastasis repair feels, that they're really snug right here. I would say most people don't find it as painful, but just uncomfortable from that feeling of have something tightly wrapped around you. Well, all of my lipo includes the OG. The OG is just the is just the line that I follow to do it. So whether I do lipo or BBL, it's all OG lipo, and it's 360 degrees. So OG lipo and lipo 360 are both 360 degrees. The main difference for me, what I think, is that I lipo high in the back. I'm very thorough through this upper area that sometimes gets ignored, and then down through the key areas, which are that junction between your flanks and the gluteal area. What garment? Oh, that's a good question, Madison. We just use ACE bandages because there's such a difference in caliber between patients' arms that I've never been able to find an arm sleeve. They're kind of like a holster that can go on here. And I've never been able to find one that's like not too loose or too tight. So I've always stayed with the ace bandage compression. But I would try something on preoperatively and see how it feels and get one size down. And you can get into that after you get rid of the ace wraps. That's for me. Okay. Sadie, you're getting mad at me here. Okay, I think maybe even you emailed me about this. So it says normal sinus rhythm, but sinus arrhythmia. But that doesn't make sense because you can't be in normal rhythm and then have an arrhythmia. So I'm not sure whether you're getting that information from, but sometimes there's an automatic readout on the EKG itself that is generated by the machine. Cardiologists don't look at that at all because it can say like acute heart attack, you're dying, and you're not having any heart attack. So I would always defer to a cardiologist. If you have an EKG, somebody should have ordered that for you and somebody could interpret it. So I would see a family doctor and ask them, but I would definitively see a cardiologist if you have any concerns. They can always repeat the EKG. They can do a longer strip. An EKG is just a very quick snapshot of how your heart is beating. But there's other monitors that you can wear, a Holter monitor that will monitor your heart's beating for a full day, a week, a month. But I would defer to a cardiologist. And if your cardiologist cleared you and said your EKG is fine, then that should not be an issue. I do transfer fat to the breast, but I do that with a composite breast augmentation. So I don't do just fat to the breast. I'll do it alongside an implant for patients that have poor soft tissue coverage. Joe Mira 1. No necesito. Okay. Can you do a chin lipo as part of an OGBBL? Yes. You can add on chin lipo, you can add on thighs, you can add on arms, you can add on mons, all of it part of the BBL. Okay, we're going to take a couple more questions. Juan is pulling the plug on me. Airway question. Okay, so that sounds like maybe you've got some nasal vault collapse from a previous rhinoplasty. That really should not be an issue from a surgical point of view for us because we're doing everything orally through the mouth with airways. Can you lose your BBL weight is gain afterwards? If you gain weight, your BBL, your butt will get bigger. So it's the opposite. All right, I'm going to take two more questions, and then we will be ready to go 99. We're going to get to work tomorrow. Yes, you can. Chin lipo is very easy recovery, and it's very easy to perform, and it's very painless, and you can add that to really any procedure, honestly. When can we sit 4 to 5 hours or more without the help? So usually what you do is you don't sit for 2 weeks after having a BBL, and then you'll sit for an additional 2 weeks. The next 2 weeks, you'll be sitting on a BBL pillow. But I would not have a rhinoplasty scheduled anywhere within about 6 weeks of your BBL because your surgeon's not going to want you laying on your nose. Okay, one more question. Is that what we're going to say? As plastic surgeons, we don't look at it that way. What we do when we do a diastasis repair is we just take the two rectus muscles, and when you're born they're like this. I guess I'll do it this way. When you have children, they spread to allow for the distension of the abdomen, and then after you have children, they will come back. They don't always come back to normal, to the midline, and so you can have diastasis, which that's what this is. There's a little gap here, and then we relocate those muscles by sewing the fascia over top. So it just depends on how much diastasis you have, will determine, I guess, the number of inches, but we don't really measure or think of it or record it or do any of that. The muscles are here, we bring them back here. If they're here, we bring them back here. So you'd have more inches removed if they're here, and you'd have less if they're here. But we don't really measure or track or think about that. Think of it in that way. We just return them to normal, to the starting position. Okay, so it's time to wrap up. I want to remind you of something. This Saturday, we're going to be going to Tampa Bay. It's the OG Roadshow. We're going to be going to Tampa. I'm really excited about that. It's nice because it's in the state of Florida, so I'm going to be doing some very rapid micro consultations there as well at the end of the day, where I can take a quick look at you. If it's like other conferences that we've done in Philly and New York, it's a very, very busy day. I go through every single topic, so there's a lot of information to give. So the consultations will not be like a normal consultation. It'll be a little bit faster, and by a little bit, I mean a lot, but just kind of getting down to nitty gritty and at least giving you an opinion. So everything I talked about tonight with, the preparation, all that for the consultation kind of goes out the window. This is a sort of come in, we'll do it, but it's really nice because you can get an opinion quickly, and see that. There are going to be the chart, the roadmap to download, and the caregiver instructions. Both of those are going to be in the comments. This video itself is going to be posted and left up for another day. And then this video will be going away. Stay tuned for November. Subscribe and turn your notifications on, because in November I'm having the same thing, a 2-day live class where we're going to be talking about the recovery from a BBL. So the other half, the preparation for these two, and then the recovery, and that's going to be really good. Started working that on already, and it's going to be a really good class. I hope to see you there. Thank you so much for watching. I really like this format. It's fun. I think I'm going to do it more. Probably do it for breast augmentation and reduction and things in the future as well. If you have any comments, please leave them. If you have any questions for future things that you want me to talk about, I'm happy to do that. Thank you very much for joining me, and have a wonderful evening.